surgery. This is the ganglion cyst, and this stalk comes from inside the joint. This is carpal bone. It comes from inside the joint. So unless you remove the stalk, you will always, if you remove only this part, it will always come back because the stalk is already there. So here how it is. This is how it comes out. So we have to remove this completely. Now, never under local anesthesia, because I think the juniors start under local anesthesia to save some money. And when you go deep down, it is painful. So ultimately, you will not be able to really go down right inside between the joints and remove it so comfortably. As when tried to do under local infiltration, cannot reach the deep areas to remove. Chances of recurrence are very high. As you know, the junior surgeons' recurrence is high because they try to do it in OPD and under local anesthesia. Surgery is to remove the stalk of the ganglion, which mostly comes from the joint. It originates. Rarely from the tendon it comes. So now, all what you need to do is, you want to remove this part completely. Now, you will never be able to remove this part and this stalk completely. Because once you enter, here it is, your vision is blocked. You will hardly never be able to see the stalk. Because by the time you try to do the stalk, it is never visible behind it. So what I suggest and do is, surgery dissect out the top and side of the ganglion. Distally expanded part will not allow enter till the base is, if the ganglion is big enough. So all I say is, dissect out the ganglion and chop it off. Now having chopped off the ganglion, now you will be able to reach at the bottom and you will be able to pass something here. Now I see one of the videos also. So now you have this ganglion. All what you can do is you can go inside and you will be able to see the bottom of it. Now enter the cyst and then can feel the bottom of the cyst. Now here is the one which is a real one. As you can see, this is the one, once they've taken it out, I am seeing the bottom. So you will be able to excise it much more easily. So now you go to the bottom, excise the bottom, and now burn this area. So that whatever, if in case you have not been able to remain inside in this thing, once you burn this area, this is the area where the thing has come. So once you burn this area, now it is a final thing. It will not come back at all. Tight layer closer, immobilizing bandage for 4 or 5 days. And this is the only way in which you can treat ganglion. I'm saying this because I think I've tried it out. I've done it innumerable times. And you can see once you remove the top, now you will see the sac and you will see the bottom of the sac. So if you have excised the bottom of the sac, you are almost sure that you have excised everything. Any questions on this before I proceed further? Today there are going to be short talks and I'll end up with the traveling, which you know I'm very fond of.
Sir, I had one experience with some sort of swelling, which I had thought it was ganglion, but the first time I removed it, granuloma and pus. So I sent it for the histopath. It turned out the granuloma. Again, after 2 months, it came out. When I again went in deep inside, I found some hole in the metacarpal, and which turned out a foreign body granuloma. I could remove a black thorn from that wound. That was my experience with such sort of swelling.
Yes, this is very, very often, more so when it is on the palmar side, because quite often something goes inside and that starts a foreign body granuloma. But this is you will be able to see it is generally not so painless. Foreign body granuloma, generally as it becomes bigger, it can remain painful. But ganglion, except for the size, hardly ever it is painful. Any other questions?
Sir, I have a different experience of treating ganglion. Sir. What I do is pass the proline through and break the adhesions and whatever cavities.
Exactly.
Inside.
I think I have done this also as a research project and somewhere it is published.
Yes,
Ganglion,
then,
I used to pass a needle through it.
Yes,
so
sir.
you pass a needle with the thick thread and tie the thread. So that
Yes,
fibrous tissue involved, that induces the fibrous tissue, and that
Exactly.
also will give rise to the relief of the ganglion. But
Yes,
then
sir.
I think there is an occasional chance of infection because everything remains open. So there is an occasional chance of infection. But still,
Sir.
it is still temporary because the stock is not removed.
Yes, sir. Yes, sir.
So you will get a temporary relief, definitely. So after doing that, tying it up for about 2 weeks to 3 weeks, in one patient I had an infection, which was very superficial, but it was there. And so I said, well, I think in a private setup, you cannot afford that. And that's
Yes,
the reason I stopped doing it and I started puncturing it out, evacuating it out. It does the same thing, inject depomedrol for whatever it is worth, and it is a conservative treatment of that.
Okay, sir. Okay.
Because Deshpande, you want to add up anything? Any experience?
The experience of recurrence of other surgeons, I never dare to operate any ganglion. I'm comfortable with earlier treatment of aspirating and putting a depomedrol. No matter even if it recurs for 2 or 3 times, I continue to do it. Then either patient doesn't come back, either he goes to some other surgeon for getting operated. But I have never operated a ganglion because of other surgeons' bad experience.
No, I think as I said once, I told you this. If you do it, you chop up the top of the ganglion, now you have the shack. And now it is very easy to remove the shack. You will be able to go down, and since it is under GA, you will be able to go down right up to the bottom and then burn it off.
I was thinking to do it sometimes, and I'll let you know, sir, once I do it in the way you told me. I'll record it as well. For the sake of my residents, I have been teaching my residents I don't operate ganglion.
No, I think, anyway,
Yes,
any
sir.
other question?
Sir, I had an experience, I just wanted to share it. 2 episodes I had in which a ganglion, they had initially done a fine needle aspiration cytology with a needle in the for diagnostic purposes to find which type of lesion it is. And then finally I went with ganglion excision. And then I had an experience of superficial infection in both of them. Now, my opinion was probably the FNAC that was done might have initially seeded something, which then after surgery, I don't know whether I'm right or not, but this is what I had experienced twice.
Possibly, because I feel FNAC somehow, majority of the times in orthopedic setup, 50, 60, 70% of the time it is negative of tumors or whatever you do it. Here in a ganglion, probably chances of being negative are very, very remote because it is so superficial.
Yeah.
But I agree. I think probably it must be the FNS because I have been doing this in the CT scan department, quite a lot of things. I do this, I allow them to do FNAC. Then the same space, I make a drill hole and go to the bone and take it out with the small forceps or the small scoop. Actually, I have the whole setup, which I take it to the CT scan. And initially I compared 2 separate tissues we would send. And about 80-90% of the time, whatever the FNSC which is done, you don't get any tissue. While we do it like a surgical removal, though from a keyhole, and you will almost always get a histology possibility. But then their sense of asepsis is not very, very good. So I always feel scared to do it. So I always go on saying, don't touch this, don't touch this, I want this, I want this. And still they just go in that and gloves wohi pehanta hai, waisa hi karta hai. So I feel you got to be very careful when CT scan people are doing it.
Yeah, exactly. I took all the precautions and antibiotics, everything still.
No, I think you and me, when we operate, we are used to that. While the CT scan walas are not used to that.
Yes.
And there is hardly any sterile things are available. You have to get all of them from the hospital. I mean, from the theater. Anyway, I'll proceed further. Sorry, anything?
In such cases, do we have any suggestions from your side to prevent the infection other than documenting it and telling the patient, I don't think you can do much because the routine precautions that we take,
Fortunately, this
antibiotics, everything
infection,
was
even
done
if it
seamlessly.
occurs, if you act on time, then it can be immediately prevented or
Yeah,
it
it's
can be
subsided.
aborted. But you
Yeah,
go
it's
on with
subsided.
antibiotic, then
Yeah, that
ultimately the
happened.
bone
Yeah.
can get involved.
Yes.
Okay?
Thank you.
Now this I feel, head is mightier than the machine. That is, I am talking about the investigations. And I have been somehow or the other, I feel in the generation, pardon me, the younger generation, have omitted the art of examination to the patient. So many times you examine the patient and you will get the few clues which you will have to fit in with the investigations. More or less, quite a lot of people depend on a disc guy and ask for the MRI. MRI shows the disc, you need an operation. But that's not always true. The investigation, particularly the we old timers, have been so used to examination. So many times I have found out a gallbladder stones, or I have found out the hepatic swelling, or the kidney swellings, or the kidney hypertrophy. All because if there is a pain in the back, you go in the abdomen and try to find out, and occasionally you will get it. So I feel now that this is the talk about head is mightier than machines. Now this is the one which is there. As you can see, this is a severe disc prolapse. There is no question of MRI evidence of a disc prolapse. You can see that very much this is a disc prolapse. This is the commonest observation. MRI shows a large disc and is advised surgery. Comes 5 days later on the day of surgery, you're in Bombay, actually we cannot operate immediately, more or less. So we fix it up and comes after 5 days. 5 days later on the day of surgery, he reports, sir, now there is no pain in the leg or the back. Do I need surgery? You examine SLR normal, no positive findings, repeat MRI, same large disc. So you cannot, because the disc which is there, it's a purely a finding of the displacement of the water. And as a matter of fact, if you can do it, even after surgery, you remove the whole disc, you do an MRI, still you will see the image of a disc. So image of a disc is not positive. If the patient has no symptoms and if MRI, SLR is negative, has no symptoms, then you, even if there is a big disc on MRI, you don't need surgery. So I think your examination is more important than the MRI findings. It is overrule the machines, and I never do this. I never advise surgery unless there is a really a bad issue which is there. Unfortunately, some healths do not. I tell you, I think that this is the incidents which I'm talking about. Dr. K.T. Dholakia, in one of the meetings I was there, and he was also there. Generally, those who have seen K.T. Dholakia, he doesn't generally talk in the meetings. He attends because it is socially required for him to attend, but otherwise he doesn't attend the meetings. This was a meeting in his own hospital, Bombay Hospital, where he was nominated as a convener of the meeting. So I think somebody, neurosurgeon, talked about 45 cervical disc surgery in 3 years' time or 4 years' time. Somehow the other KTD at that time got really annoyed, and out of frustration he got up and said, I'm sorry, but I'll have to say that I have been practicing for such a long time and I've been seeing so many cases of cervical disc, but hardly ever I need any operation for cervical disc. It is, if you wait long enough, all of them subside. Just because there is a symptoms, do not operate. And majority of the times, cervical disc also subside. Today, I think my incidence of a large intervertebral disc surgery has gone down so dramatically that I treat them with the root block, and 99% of them, they all subside in due course of time. So anyway, the surgery of the disc is only on the findings, and it is not on the MRI findings, only on the clinical findings. That is the only way you can do it. Interesting experience in early days. When I started practice, not yet become as successful, a successful senior GP had a patient, I advised MRI. At that time, he was more successful than me. His head overruled me on my MRI. no unnecessary expenses. He was bothered about the expenses. It was not an ego problem. He was bothered about the expenses. The TB spine was missed. Detected 3 months later when the same patient I examined by a fresh GP who was not as successful. So I think the whole decision making is also very, very dicey. As I said, I think in a interior, probably you don't see TB spine. You may not be able to see in very, very early phase. But I am in Bombay with the well-to-do people. When you're practicing, you quite often see TB spine, which is almost starting. And all what you can see is that pain, which is not explained by a disc and other things. You ask for an MRI and you will see early signal changes in the disc and in the intervertebral area. And you presume because of the symptoms only that it is TB spine. Histology, because you cannot do biopsy of that area, so you'll have to treat exclusively onto the suspicion of TB spine. And a therapeutic trial becomes the only way, which is at the moment into the lecture badges, we recommend that no therapeutic trial of TB spine unless you get the diagnosis. But in the early phase, you are never going to get diagnosis. And if you don't get diagnosis, you can't wait for the histology or a pus to form. Patient is symptomatic. So ultimately, it boils down to that you will have to give a therapeutic trial of TB. So TB spine is one entity where very early you can detect, where in the MRI, all what you see is the end plate, there is some inflammation. And this is all what is there. And if it fits in with the symptoms of the patient, then it is a tuberculosis. Head takes decision due to several reasons. Trained mind decides on logically developed algorithm. Head also decides on past successes. Unfortunately, most of the time, head is not there in picture. We only work from the spinal level. Now, I am absolutely sure all of you are working, and when you're working, you've seen a whole 3-4 hours of OPD, and somebody comes late at night, in the evening, or the last patient. Quite often, I have done it. You ask for an investigation because you do not are in a mood to examine the patient in detail if he has a lot of problems. So you ask for some investigation and ask him to come on the next day or the day after, whenever the investigations are ready. And then you can really put in your mind to examine the patient. Because once you examine, you find out the things, so many things which otherwise you will never be able to find out. Lateral thinking, Edward de Bono, I think I have already spoken about it. Most of the time, once you become experienced, your mind starts telling you without any reason that probably this is tuberculosis. Then you can reason it how your mind has come to conclusion. This patient has a severe pain for last 6 weeks, 4 to 6 weeks, not responding to the treatment, and he is walking with the severe spasm of the back. All what you need is this is tuberculosis until proved otherwise. And you do the things and then you will find a tuberculosis. Successful people in one field. This is my very bad experience. Successful people in one field, their head takes decision in unknown field also. Uneducated mother-in-law decides about highly educated daughter-in-law due to old faulty sasu stature. This we have seen it again and again happening. What is the clinical medicine today? Examine, suspect, investigation. What investigation is decided by our head? If investigation do not prove the diagnosis, we go back to our head, treat malaria, TB, etc. We are only on a gut feeling. So examination, now today, is in the Bombay setup where I am working. Non-traumatic issues, when the patient comes, they come so very early, like a disc or a AVN or anything. There may not be any findings at all. So it is the level at which we see the patient quite often. So that's the reason when you examine and you have to suspect, there is all what I can find is minimal external rotation in the hip is restricted. And then I have to feel that this may be avian. And I have to ask for an MRI. And that is the way in which you will get the earliest possible diagnosis. But if you depend on the investigations, by the time the X-ray is always normal, so you carry on with analgesics, and by the time you ask for an MRI, it is going to be too late at times for do a cold decompression or anything. And that's the reason the MRI becomes the only way. So when to ask an MRI, it purely depends on your examination. So if investigation do not prove a diagnosis, then all what we treat is on a hunch malaria, TB, etc. on a gut feeling. Now here it is that there was a waddling gait and difficulty in walking. X-ray pelvis normal. Head doesn't accept. Why a waddling gait if the head is normal? And hence I asked for a X-ray with pelvis. I mean a X-ray with upper third of the femur. Now you can see here was the X-ray which showed normal, but I took a bigger X-ray and you can see the small loser's zone. You can see actually you can see the fracture here. So that's the reason why, only reason I asked for it is waddling gait, X-ray is normal, is not acceptable. Something is wrong. So first is we wanted to ask for a bigger X-ray to find out. If in case it was normal, then we would have gone one step further and asked for an MRI. But this, it shows very well. So even this is often missed in a clinical portable X-ray pelvis. If you are in your examination, in your nursing home, you do the portable type of a comparatively not very, very powerful X-ray machine, you may at times miss it. And that's the reason why it's very difficult to really ask for the patient's treatment unless you have the full information. And this can only be decided by the head. Unless you examine the patient, you will always miss it out. Insufficiency fracture, in our language, stress fracture, need vitamin D3 estimation and DEXA bone densitometry, or be practical and give 1500 milligram daily calcium in divided doses plus vitamin D3 without investigation and see. This you can do it in the setup in which you cannot do, because vitamin D estimation, it takes a long time and it takes quite a lot of money. So you can as well treat, majority of the people have vitamin D deficiency. You can as well treat them on a vitamin D and a calcium therapy and see for some time. Now here it is, this fractures in a due course of time only with the calcium and vitamin D, the whole thing completely heals up. So this, if you are not diagnosed only by clinical ways. Now here, this is the one we already spoken about it. This is not AVN. This is the typical, this is AVN, this is not AVN. So many of the radiologists, we have spoken about it when we spoke about AVN, but so many radiologists will report this as AVN because of their not very familiarity with the other entities. This is a typical called idiopathic osteoporosis or a stress fracture or whatever you call it. Because as you can see, in 8 to 10 weeks time, same patient, he becomes 100% normal. But then one had doubted terminology, and now it is understood as an insufficiency fracture, vitamin D and calcium deficiency, but always you never find that calcium or vitamin D deficiency. My observation is quite often you see this without really any problem, even in a younger people. But today I think the radiologists have coined this as an insufficiency fracture or whatever it is. So vitamin D and calcium will allow healing in 6 to 8 weeks time. This is all information stacked up in some corner of the head. When you see MRI, reflexly AVN is ruled out and calcium is started. This is a lateral thinking which is also based on the past experience. Now here, this is also the observation. Here if the X-ray, this is a 4 months X-ray, you will say the fracture is not united. 7 months X-ray, still the fracture is not united. But my philosophy here is, if this is the implants are holding for 7 months, one question I ask, do you have pain in the fracture area? And patient says, no, sir, I have no pain. But the radiology is not behaving. If you see, starting again from the beginning, this is the lysis has occurred here. This is attempted healing 4 months, 7 months still there is no healing, 9 months no healing, 6 months, 9 months no healing. But you can see, since there is no pain, I went on. Because you carry it on. Since there is no pain, the hardware is holding, this fracture is going to heal up. And as you can see, it started healing up. It started healing up in 10 months time. And ultimately in 2 years time, you can see the whole thing is healed up. So it may heal up less. Now you will get the same result if you put a bone graft here. Or if you put in a bone graft here at any stage, you put in the bone graft. It will heal up because it's destined to heal up. And this I have collected plenty of cases, I think we have spoken about it also, that if the implants are holding for a long time and patient has no pain or hardly any pain, you hold on, chances are very high that it will heal up. Now, obviously, the question comes, the patient shops around and somebody advises operation, somebody advises hold on. Most of the time, those who are advised hold on, the patient will agree because he also doesn't want another operation. And it can heal up. It may take a long time, but it will heal up, as you can see very well. Same patient, everything becomes perfectly normal. Young man of 30, pain in the hip joint, 4 months. Movement normal, but the pain on flexion and adduction. X-ray normal. No local tenderness or any positive history. X-ray normal. MRI non-contributory. Now see the again. Examination, young man of 30. Pain in the history of 4 months. Pain on flexion and adduction. This is all what is the finding. But X-ray normal, MRI normal. Now what am I going to do? Symptom persists 5 months. MRI normal, but persistent pain. Fortunately, the buck stopped at me. I asked for a CT as I felt MRI was negative. There should be CT. And he has findings on examination. And here I was most pleasantly surprised to see this small area. MRI normal, so I asked for a CT. And MRI, since it was negative, a young man of 30, pain in the hip joint, 4 months, movement normal. Movements normal, but flexion adduction painful. No local tenderness or any positive history. X-ray was normal. And that was the cyst which was seen here. Now that cyst, I went down and I operated upon from anterior approach. And you can see this is intraoperative findings of the cyst. I went there. This was intraoperative finding of the cyst. You can see very well I curated it out. I curated it out and I grafted it with the artificial bone. The whole thing was curated it out. Biopsy was taken, and this biopsy was reported by one of the senior most and most respected histopathologists, Dr. Borges, and she sent me this with the literature. I wasn't aware of what it is. It's herniation pit of a femoral neck. And this, all it says is synovial membrane here, it goes inside and it forms this pit. It is known as a herniation pit of a femoral neck. This is the article which has appeared. So all what I can say is, only reason why herniation pit, that is synovial pit, synovial membrane goes in the bone and erodes the bone, making this benign impression on the bone. Why pain? Here it is unexplained. Cure? Why it is unexplained. But he had a herniation pit, and you can see it very well. The only finding, as I mentioned, was some restriction of movement. So head is stronger than the machine, because what the investigation we ask is also based on to our thought process. This is the 40-year-old patient, pain in the hip. These are my findings. Here it is my case sheet, which I give it to the patient. 40-year-old, 2 months, left hip, investigated flexion and internal rotation restricted, and he cannot squat. And I see I have marked it. I have this sort of a OPD paper where I do it so that I know I'm talking about the left hip, and the main gist of the thing comes here. So flexion and internal rotation restricted. So now this was ultrasound, pelvis with both hip joint and left hip joint. Bone shows early changes. Radio opacity is noted in the pelvis, likely suggestive of phlebolith. Sclerotic opacity needed in the neck, femur on the greater trochanter, bone island. So that means basically it was negative. X-ray was negative. Non-collateral helical scan was done, performance, multiple things, the impression there are sclerotic areas in the neck, intertrochanteric region, left femur, probably bone island. Subchondrosis is noted in the posterior column of the acetabulum. Now, all these things could not be explained why the patient had a pain. This was the MRI finding. This is how he was. Impression, normal steady pelvis and both hip joints. All these are the reports by a very, very well-known Bhavin Vakil, who is in a chief of Bhatia Hospital. Now, I could explain my finding. 4 months had gone by. Flexion and internal rotation restricted. Cannot squat. 40-year-old, 2 months, now 4 months have gone. Still, this is the finding. Pain persists. Deformity persists. MRI reported normal. I was uneasy. I ordered a CT scan as I felt findings have to be explained. And there you can see the CT scan. This is where it is. Small lesion. Now, if you see somebody had reported something on the CT, the MRI, but he had felt it is normal. I think there was an MRI finding which was showing subchondral cyst noted in the posterior column of the acetabulum. Now, I couldn't really locate it. I spoke to the MRI person and he also felt there is something, but I think it is normal, sir. Anyway, so this is how we proceeded. And here was the cyst. Now the flexion extension, you can see these findings, which was there definitely seen in the CT scan, which was not picked up in MRI. Now you cannot really do the histology of this. All I did again was, he has a definite, now these are my notes after seeing. He has a definite symptomatic hip restriction and pain. MRI is normal. CT, there is a lighting area in the acetabulum. There is no obvious positive diagnosis. And a biopsy of this CT scan lesion is only a way ahead. I feel with his symptoms, you should try anti-TB as a therapeutic trial and reassess 6 weeks. Tablet AKT4, 1 sachet a day, and Neurobion. This is how I advised him. This is on the, and now this is 11/10/2006. 40% better, 2.5 kg increase. Abduction and internal rotation shows restriction. Movements improved, but only 25%. CT anti-TB and C again 6 weeks time. I felt it will a biopsy, it will harm him because from this area, you really will not be able to do biopsy and it will not be positive and it will not be worth it. So as symptoms of movements restriction and flexion deformity, I treated on therapeutic trial on anti-TB. In spite of respecting Dr. Agashe, who has been talking about never treat a TB without a biopsy report. I respect as a person, not his views all the time. Now here is a 20-year-old hip pain. Why Dr. Agashe's thing has come? Because he was one of the faculty in this meeting which I spoke about. Now here is the patient, 20-year-old hip pain, 3 months movement. Movements restricted 40%, 10-degree flexion deformity. And here it is MRI. This shows tumor. 20-year-old hip pain, 3 months movements restricted, 40%, 10-degree flexion deformity. And this was considered as a tumor. Beja mein kuch garbad hai. MRI shows query tumor. This is how it was reported. In Mumbai, in Bhasha mein some chemical locha. 20 years old, 3 months problem, hip flexion deformity. Tumor means biopsy means hip exploration and permanent deformity. And if it didn't turn out tumor, then what? 10-degree flexion deformity. Radiologist I respect asked for a biopsy. My faith in CT-guided bone biopsy is not very good in most ends. I asked you, as I mentioned to you earlier. I asked for head for a CT. In spite of some lesion, I asked for a CT. And this is what was the CT. Now I was convinced there is something there. My head argued that if the tumor is benign, not malignant. If malignant, it is never going to be normal. If benign, 6 to 8 week delay will not make a difference. Discuss with the patient. Sahayata mein Bhagwan. This is how the patient tells you. With this lesion, it's not a tumor. therapeutic TB trial, and he was okay in 4 months' time. Basically, the examination leads to one thing, to other thing, to third thing. Clinical examination is still the king. If the findings do not match with the investigation, go more into details. Either you have not investigated enough or science does not know about this entity. That is our escape. This is 24-year-old pain, minimal in it. You will see there is a lesion here. This is the MRI. This was treated as an AVN on a MRI report. Fully mobile, no restriction, no deformity. Now you can see this, minimal pain, fully mobile, no restriction, no deformity. He was still treated as an MRI, was advised core decompression. You may know very well that AVN asymptomatic on one side with such a MRI finding most unlikely. So we couldn't put this MRI finding, this X-ray, and this normal hip. So now this was the hip. This is the X-ray finding. This is the typical hip in T1 and T2. Reported outside Bombay as AVN. Didn't fit into my head. No deformity, no restriction. MRI, localized lesion, no symptoms, cannot be MRI, cannot be AVN. Didn't fit in the clinical examination. CT guided biopsy, I did it. This is how typically the biopsy was done. Left hip bone cartilage is neoplasm, possibly enchondroma. Anita Bodhis, again, she, as I said, she is one of the final word in Bombay as far as the histology is concerned. This was her diagnosis. Treatment was simple. Went in anterior and scooped out, then erased with the burr and grafted. There it is. I went in, erased it out, grafted it, and that was the end of the story. In these days of MRI and sonography, clinical examination is losing its importance. Here I am, old-timer is reminding again of clinical examination. This was again a 32-year-old young male came with pain in the right hip with positive findings of inguinal area tenderness. No hip deformity, nothing. Only inguinal area tenderness. MRI reported effusion in the hip, symptomatic treatment, no relief. Now, effusion in the hip and nothing else is there in the MRI finding. So successful GP, finished the round of consultation, elimination of hernia, varicosity of pelvis, oncologist, all normal. Well-to-do person, so went through the whole cycle. Inguinal tenderness. The patient, I think, had trust me somehow, so he comes and tells me, "Kuch to karo sir. I cannot tell like this." I only told him, hang on with me for 1 month, then we shall go through the cycle. Because I think if you just do one investigation is not all right, I am not going to take you up. So here it is, this is my findings, 2008. 10 months right hip pain and limb, difficulty in walking. Increase for 1 month, right hip abduction and external rotation and pain on flexion with flexion restricted. Abduction good, adduction restricted, and a good rotation. Good rotation, flexion rotation restricted, inguinal ligament area, severe tenderness. 5 months back, all investigations were normal. X-ray shows right-sided extra body in the X-ray, which does not seem to be any symptomatic. So, and the MRI is normal, no constitutional symptoms, and everything became perfectly normal. This was the only X-ray finding which could not be explained. I said, this is this X-ray finding in this patient. Kuch to hoga, ye X-ray kaisa hai. So I spoke to the MRI person, and MRI person says, "I'm sorry, sir, but I can't find anything in MRI." Now here is a beautiful note. Dear Bhavin, now again, I trust him. I really respect his acumen. Dear Bhavin, he needs your early morning attention. Obviously, he phoned me back because he could really read the sarcasm in it. Right hip has definite signs, though mild. MRI effusion. Right hip X-ray bony projection is not explained. Right hip X-ray bony projection, I put it down. Bony projection not explained. Inguinal area severe tenderness, unexplained. So fresh MRI and do what you like. This is what I send him. Do what investigation you want to do what you like. All which he said is, patient has the symptoms, everything is normal. I was not willing to leave it. And this was the finding which couldn't be explained. So I said, do fresh MRI and any other investigation you need. Resolve for me. So now he went through, he did MRI, he did CT scan, and then came up with this. This is the typical area which is formed here. And he said this was his diagnosis. Correlating with MRI, it appears there is an overgrowth of the bone at the origin of the rectus femoris tendon, with altered signal and irregularity at the origin of the tendon. Slips a little more posteriorly as well, all suggestive of chronic avulsion sprain. The rest of the features are described. Chronic avulsion sprain. This is exactly what it was described. Once he described that there is now nothing, this is how it is. Here it is a typical way. Now I know what is the cause of pain. Here is the area, rectus femoris, from anterior inferior iliac spine. This is where it, now we know what is the issue. Local depot did the job. At the local spot, I injected depometron with xylocane, and immediately the pain went away. That is the spot I injected, and immediately the pain went away. So progress of this case, in last 3 years, he had about 3 injections and improved dramatically all the time. Today, he is asymptomatic with minor hip restriction. You would never have been able to diagnose unless you had relied on the investigations and relied on the findings and investigate. He was that. My sarcastic letter to an excellent radiologist, early morning attention by a radiologist. So he really literally took him up at 7:15 when he starts. And that was the first case he did it. And by the evening, he sent me all these reports. And he said, sorry, sir, what you say is true. My clinical findings, which could not be explained, was the other key that suspicion went through and through. Left hip pain started. This is, I think, another patient, but let me see. Left hip pain, 6 months started after a cricket small jerk. Pain immediately, few days later. There was no pain immediately, a few days difficulty in sleeping on that side. COVID in May 21, 4 months back, taken cortisone 8 days. But the pain left it before the COVID also. Today on examination, flexion and internal rotation markedly restricted. X-ray normal, MRI effusion of the joint, no bony involvement. Disproportionate pain and restriction of the hip. X-ray MRI not significant. Uric acid 9.8. So again I found something. But I said uric acid 9.8 cannot have these findings. These findings are not something which I can explain. No general signs of tuberculosis. Better with combiflame temporarily. And ultimately tuberculin test negative. So I was quite now perplexed. What is the problem? Mild to moderate size left hip joint effusion with no associated things. Yeah, so this patient, I put him on to anti-TB treatment. He is still under my care. Now he is 3 months. As far as the hip is concerned, he is 100% cured. Now, only thing is I couldn't explain the finding. His BON2 was negative, which never happens. So I said probably his BON2 was negative because the pathology who had done this is not a regular pathology who has a volume. So quite a lot of times they inject BON2 serum, which is probably not really active. MRI was negative, but physical findings were positive. All I had was the physical finding. And on that basis, I put him on anti-TB. And today he's about 3 to 4 months and he's perfectly all right. And he's taking the treatment. We all doctors are biased. We trust expensive investigation, but not our well-trained, God-given free head. Lessons learned, we all doctors miss many things at a time. MRI report is not everything. My note to our radiologist hurt him and he stimulated him. Dear Bhavin, he needs your early morning attention. Clinical findings are supreme. These days of MRI, we have forgotten clinical findings. These are the clinical findings which put me on to this extra bone, this tuberculosis and everything. These are the few I picked up. There must be many I must have missed which were picked up by others. I'll be a fool if I believed I only have a head. I'm sure all of you must have observed this. Now, last, I want to say my own case. See, I had some food and I got a tremendous distension. And I was very uncomfortable in the middle of the night. So middle of the night, Dr. Tanna, who was a teacher in a medical college, all my students were now in a big position. So I phoned up one of the GI chair, whom I had operated upon for his fracture fever. 2 o'clock at night, he came over. He took me to the hospital, ruled out any gas under the diaphragm and pancreatitis. He said, sir, there is no pancreatitis, there is no gas under diaphragm. So there is nothing emergency. Tomorrow we do all investigations. All investigations were done. And he asked for a CT. I got a CT done. And CT scan, excellent CT department check.
Sir, images are not seen on the.
Sorry?
No,
there are no pictures. There are no pictures.
Okay.
No, there are no pictures. I have not included that because this is non-orthopedic. So I am talking about my own self. There are no pictures. Please understand. Now, where was I?
Got CT scan done, sir.
Yeah. The CT contrast was done. And CT contrast showed a tumor in the pelvic area. The good radiologist who was doing it, he reported this and he said, sir, this is a tumor in the pelvic region. There was a very, very competent surgeon who was also there at the time of CT. And he also showed that, sorry, sir, there is a tumor there in the pelvic area. So I asked him, that surgeon, do you need a second opinion or you need anybody to have a look at it? He said, yes, sir. As far as you are concerned, you take a second opinion, but I don't think there is any need for that. But still, in any case, you ask for it. So I went to the radiologist whom I trusted, Dr. Bhavin Jankharia, and he also, I knew him personally, I knew his father too well. He said, yes, sir, I am sorry, but there is a tumor. So now one surgeon I had shown, one radiologist I had shown. So 2 radiologists and 1 surgeon, they say there is a tumor. So the same day evening, I phoned up one oncosurgeon who was in Goa, and he came at the airport to my house at about 10:30. He examined everything and he said, sorry, sir, this is tumor, you need operation. So we fixed up the operation. And I told my physician that this is what has happened. My physician, he said, sir, I have examined you. You had no past history or anything. You have nothing in the findings. You are absolutely normal now. Let me do a colonoscopy and then decide whatever needs to be done. Now, see, by this time, I was already fixed up for surgery, malignancy, and so the whole cycle in the mind, everything continues. But that physician, he insisted that no, I think we do everything after I see you on the colonoscope. And I was to go on a holiday, which I had cancelled. I underwent a colonoscopy under anesthesia. He didn't find anything in the area which was there. So he took me back to CT scan. They did again the CT, which was the area which was affected. He again went in, he was there colonoscopy doing it for 1.5 hours. And ultimately I was brought out and I was announced, sir, you have nothing. That is about 8-10 years back, I think. I'm 100% normal. And you imagine the best of the radiologists were involved, best of the surgeons were involved. So there was no issue of anybody's skill or anything. But the findings by that physician, sir, you have this, I cannot explain this, but let me do the colonoscopy before we go ahead. And obviously I didn't need anything. I am back to normal, 100% dancing around, moving around. So I feel that examination and the findings of the machines, if we rely on, we will probably regret often enough, unless it fits in with your examination, and that's the only way in which you can really treat. Any questions on this? Anybody?
Good evening, sir.
Yes.
So in your case, if you had not taken the colonoscopy and gone ahead with the surgery.
No, I had not gone ahead.
No,
Won't
sir.
allow me.
In case.
But everybody else said, sir, this is 100%. The surgeons, the radiologists, they didn't want to do colonoscopy.
So God forbid, and if you had undergone the knife and opened up and seen inside there was nothing and closed out and come out, then what?
Exactly. But as I said, the physician whom I trusted, who had come at the middle of the night, he was in the picture. So that he said, you just tell me, sir, what is it? He was in the picture, and I wouldn't have undergone surgery. But since these two giant of surgeons and two giant of radiologists said it, I fixed it up before I underwent a colonoscopy. So basically, head is stronger than the machine. I think we have forgotten the art of examination of the patient, which we must. Any questions?
Yes,
Exactly,
sir.
sir.
I have a question.
Bolo.
Sir, that is regarding the vitamin D deficiency which you showed about. Sir, most of the patient ask about that I have taken vitamin D3 dosage and one injection and completed 10 weeks of sachet and regularly taking this bio D3 tablets. So, is there any side effects or stones or any toxicity occurs? So, sir, how you deal with these patients?
Sure, as an orthopedic surgeon, we do not know much. But I'll tell you the toxicity of vitamin D. On 3 occasions I have treated. Somebody had given vitamin D and vitamin D was 11 or 12. We bombarded with the intramuscular and vitamin D every day. At the day of 15 days, he started vitamin D daily, 60,000 doses. Unfortunately, he was an uninformed physician, orthopedic surgeon. The patient goes into a severe hypercalcemia. The serum calcium was 18, and they go into a hell of a problem. And the kidneys really back off. Patient was hospitalized only for this hypervitaminosis D. So that's why you got to be careful that vitamin D is once a week, 60,000. Then 8 weeks is more than enough. And arbitrarily repeat every year for 8 weeks. That's the dosage of that. So if you are there, vitamin D complication can be severe. Calcium complications are not as much, but vitamin D complication can be severe.
And sir, any clinical symptom or anything, any complaints if a patient comes with hypervitaminosis D like polyuria or something you have come across? No.
Just a minute. Can you please repeat? Sorry.
Sir, I want to ask if there is, if you have experienced any cases where there is increased calcium levels, and what are the clinical findings you have in such patients?
Those three cases, they are nausea, vomiting, kidney failure signs.
Okay.
And it was very clear to the physician who came into picture. The radiologists were confused, but the physician was very clear. Sir, this is vitamin D toxicity, and all what you have to do is the dialysis. You have to do the dialysis, bring down the calcium for 18 to really low down.
Okay.
So you
And
said
sir,
vitamin D for 8 weeks is good enough, so in the entire year.
If it is yes, I think it is good enough.
Should we get a vitamin D level, sir? Or
sorry?
Should we get vitamin D levels at the end of the therapy, or a DEXA scan? Or...
They are always normal. Vitamin D levels are always normal. You see, after 6-8 months, again it goes down. Then there is an arbitrarily I give every once in a year. And if in case it has gone down in between, then arbitrarily I give once in 6 months. 2 months of dosage. Ideally, as you know, you do vitamin D3 estimation. If it has become normal, now you do after 3 months. If it has gone down, you give it. This is ideal. But even in the city of Bombay, with the well-to-do people, I have not been able to practice that. Because you say, "Arey sahab, iska to kuch," if I remember, vitamin D3 testing itself is about 800, 700 rupees. So I think they hesitate about it.
Okay.
Secondly, sir, you mentioned about examining every patient in a busy OPD, especially in a government setup, sir. Actually, it is not feasible, sir. And so writing an investigation in such cases is actually a bailout option, sir.
Wait a minute, better. I have also worked in a government hospital.
Sir, but that's why I asked you this question, sir.
I tell you, in Nair Hospital where I was working, same situation. The house surgeon is only doing CT all, he is not seeing any patient. We had established a system where the senior person, senior registrar or a senior person would examine all the old patients which were supposed to be seen by the physician, by the house surgeon. He will examine 20, 30 patients till the time he is exhausted. And he will examine those 20 patients like any normal consultation room. And he will pick it up at least 5 to 6, which have been continuing the purely CT all. They are continuing there, have some problem. We bring them out, investigates, and we treat accordingly. This is all what can be done. As a senior person, what they used to do at the end of the biopsy, at the end of the OPD, they will come out with those 8-10 cases which they have found something odd, and we would discuss them out and probably solve that out. But what you say is very true. At a junior level, there is nothing much you can do when there is a 300 people and 400 people you have to see. It's damn difficult. But as a senior level, you do not see 300 patients. You have to see only those 10 patients.
Sir, your indication for injection Arakitol, sir?
Hardly ever I give it anymore. I have found it in the literature. Intramuscular injections, Arakitol or any of the things is not superior to the oral treatment. And so I have never, because it is painful, and if they take it from hot places, they get infection also. So I hardly ever, I have never given the Arakitol injection in last so many years.
So people have also we have also given Arakitol orally.
Absolutely. Arakitol orally is absorbed, so it is useful. I think those people who are not reading, they feel intramuscular injections have been absorbed better. As a matter of fact, it's the other way around. Arakitol intramuscular is at times not absorbed compared to what the oral is absorbed.
You
Any
said
other
about
question?
8 weeks of vitamin D3 oral tablets once in a week. Many times in almost 10 years back, injection Arachital was given once in 15 days for six shots. This is almost like 3 months. So was that causing? And now the
I think
region
at that time, whatever the knowledge available to us, we were doing it. No? Ultimately, the knowledge is changing. I am sure all of you have changed the treatment modalities over the time.
Yes.
Ultimately, today also what we feel, we know, but in 10 years' time, so many things are going to be obsolete. So we can, as a medicine, we can practice only what the science knows. And only what the science knows into the world, what you and me know about that, only that we can practice on our patients.
So I don't remember currently with one of the articles with vitamin D3 pertaining backache with mechanical backaches. They have advocated with vitamin D3 tablet once a day for 10 days and then switch it on to once in a week for another 4 weeks.
See, I think it has to be, one article doesn't mean anything at all. Today you want to find an article on anything, you will find the article on both sides. So that's not what we can really rely on. It has to be peer reviewed. Many more people should have observed the same thing. Then only it becomes a science. Otherwise, it's article writing, as you know. Everybody is in article writing for their promotion, for their CVA upgrading. That's the reason why it's not really. Today, I feel the article reading or article writing is very dangerous. You get carried away quite a lot. Any other question? Okay. I think I have finished orthopedics. Now I'm going to talk about a few non-orthopedic things. Something which I feel Can you see my slide?
Yes, sir.
Can you see here?
Yes, sir.
Me dancing around, you seeing it here?
Yes, sir.
So now this is my, as I said, these are the two non-orthopedic talks I want to give. Most doctors do not live their life to the fullest. And I very, very, very passionately believe that. Most doctors do not live their life into the fullest. At the age of 73, I was doing this recliner, and still again at the age of 80, I have done it again. I'm sorry, I'll be talking a little about me because the subject demands me to do that. I cannot talk about some fictitious character of novel and say what I feel I want to convey once I accepted to talk on this subject. This is Dr. Ho, this is Dr. Babulkar, and this is me dancing around with this chap who is being there. So I am going to deal with the academic, ethics, economics, and extracurricular life as one continuous overlapping life process. Life, there are no compartments. Whole life merges in one continuous process. I think this is the crux of the whole thing. We are son, student, husband, father, doctor, friend, speaker. And our happiness depends on all of this. It doesn't depend on orthopedic success. Life of most doctors is work, and more work. We take pride when we are working at 12 midnight. My friends ABC and XYZ are at their best at 3 a.m. when they are winding up their work. I know of 2-3 people at least of this time. That is the time when I am about to get up and read orthopedic and esoteric non-orthopedic stuff and prepare to go for my golf or lovely walk in the park or a swim. Let me make it clear. They are not unhappy and they are not wrong. All I say is some are different than them. They may be saying this crazy Tanna gets up at 4 a.m. and wastes his 3 hours time in playing golf. I feel they are justified. So whichever group you belong is okay. I say hi. I have no problem if you make more money. But my problem is we only make more money, whole life takes a second place. And the main is more money is necessary, but life is not all money. When I was young, Oscar Wilde said when I was young, I thought that money was the most important thing in life. And now that I am old, I know that it is. Doctors, and I agree about it. You need money to enjoy life. If you don't have money, you will never be able to enjoy life to the fullest extent. The doctor brothers from Nashik finished world's toughest cycle race. These are the two doctor brothers, Jitendra anesthetist and Mahendra dentist, for the 4,800 kilometer cycle race event known to be the toughest in 8 days and 14 years. So these are the practicing doctors. He did this. After a certain point, money is meaningless. It ceases to be the goal. The game is what counts. Aristotle told every rich person says this, but every person who is making money and would need money, we have to make money. I have no issues about it, and I have also made enough money. Dr. Murud Lala, oncosurgeon from Hinduja, only doctor to climb Everest, and still he is practicing oncology. My very good friends ABC and XYZ are very, very decent men. They are not running after money. They enjoy excessive work and are superb in their work. I also got partial opportunity. I chose my path. I'm not bragging it is better. It is different. And I am happy. That's why I say yeah. My problem is I read too much of esoteric stuff in my childhood and in my youth. Wealth is the ability to fully experience life. And this is what Thorusi said. This is 6 of us, Babulkar, Kulkarnis, then our 3 wives. Equator, center of the earth. This is latitude 00. Where you are at the center of the earth, which is totally different. We enjoy doing this. Society equates wealth with wisdom and efficiency. And I do not view wealth as something that validates my intelligence. Steve Jobs, beautifully founder of Apple Computer who died in 50s. See this sentence, I do not view wealth as something that validates my intelligence. People accept that the wealthy people are more intelligent. That's not necessary. Anand Joshi, he cycled around the worst terrain of India. And still, as all of us know, he is a very active orthopedic surgeon. This is the thing which is worth reading it. Gail Saini, she has written this thing, Passages. And this is the preemptive he has done. I wrote Passages to try to understand what I was living. My own midlife crisis was premature. It was precipitated by a shock of finding myself in the middle of the terrorist event. I was in Northern Ireland on assignment for a New York magazine, interviewing a teenage Catholic boy after peaceful civil rights march. When the British paratroopers jackknifed out of their armored cars and started shooting, and the whole hell broke through. And then he writes down the bullet which came in. It came into about few degrees onto the one side, I would have been dead. So she said, After return home from Northern Ireland, I was unable to write a story about Bloody Sunday because I couldn't confront my own mortality. I was only 35, but some intruder shook me by psych and shouted, "Take stock. Half your life has already been spent. What about the part of that you want to, who you want a home and talk about a second child? Words, books, demonstrations, donations. Is this enough? Suppose you died tomorrow. What of the lasting value you would have contributed to the world? To be confronted by the first time with arithmetic of the life unnerving." She shook the like that and she left everything and she wrote this book, Passages, which has made a fortune, and afterwards she has written many books. What most people dream: I'll make lots of money and then go and see the world. One cannot go for the 6 months trip and see the world. It will be boring and not exhilarating. This is me doing scuba. I have to see the world bit by bit to enjoy. And that can be done only by us, only along with medical practice. This is a lovely scene in Antarctica. You can see the penguins in thousands and thousands of them. What is success? What we all think: when I make enough money, I'll travel the world and I'll play golf and I'll retire and spend more time in gardening. None of us will be like Ambanis or Tatas or Birlas. All doctors, we are not destined to become like those money icons. How much money you need, nobody has been able to say it. But this is only one life. No money will come with us. So whatever you want to do it now. There is no future. Do it now. Nobody ever thinks as a doctor he has made enough money. And if even that gnan dawns on him, he is way past his youth. Then he will not be able to do mountain hiking or play tennis or a bridge or learn golf. All he can do is to count his money and drink. How many doctors have done it? See your teachers, your seniors, your idols who have become successful. Success is climbing a ladder and not reaching at the top. When you are at the top of a small hillock, you always think of a still bigger mountain and ultimately the Everest. And often later, we realize the ladder you climbed was on the different wall and one has missed the real ladder you wanted to climb. All this, if you want to do, rethink your mental process. Make money, but do not neglect life. In no time, you will be old, and that wonderful opportunity to acquire new skills and visit a new destination and think of a new girlfriend will all be unattainable. Time is now, not later after you have made money. There is only one success: to be able to spend your life in your own way. Have no illusions. If you work too much with patients, you do not necessarily become better. Science is changing very rapidly. If you do not read, you are gone. If there is no time to read and think, one will not be that cutting-edge doctor. One needs a lot of spare time to analyze critically and needs to develop that mind to do it. One does something because one likes to do it. Then there is fun, not because one has to do it. Then there is boredom. Dolakia and Talwarkar and Mukhopadhyay and all known tycoons were the same normal human beings. They were successful not because they were more talented than most of us. I firmly believe once you and me have become doctors after so many screenings and so many rounds of elimination starting from KG to postgraduate, we are all cream of human quality. The Cain Mutiny has beautifully mentioned a letter to his son. This is a story. Time is now, not when you make more money. And he has written a letter to his son. He says, you open it up only after I am dead. And when the father dies, son is so keen to open up the letter. And father tells the son, the time is now, is like a point of fulcrum. Whatever you have become, you have become. You are not going to become anything different now. So you do whatever you want to do it now. If you wait for more time and just spend your time acquiring more money, you will be wasting your time. You will not be able to do what you want to do. Those who have played bridge and chess know it's churned your mind and makes you restless when you have made blunder in the last night's game. Dr. Tibriwala, pediatrician, was all India bridge champion, along with the excellent pediatric practice which he used to do. But also forms a habit. At last game which is over, now we are playing a next, so it introduces the mind pattern of putting in the box. Like do the other surgery when something had gone wrong in the previous surgery without disturbance. This Dr. Hemant Morparia is a radiologist and cartoonist and an art commentator and a painter. You can do 1,000 things just because you are a doctor. It's not that you cannot do many things. This is all along medicine. What is after medicine? I'll continue to enjoy that time Bhimsen Joshi and Tendulkar. Take a buggy and pretend to play golf. And enjoy reading authors about existentialism by Jopo Sartre and Colin Wilson and Albert Camus. I'm sure 95% of the people whom you do not know, these are the exotic authors which have written lovely things. Play bridge with small stakes because not earning fresh money will make me miser and will never stop learning life from all of you. Oval at the pretty ladies, that will be all I'll be able to do. And I'll be able to do all this only because I've done all this along with orthopedics. So all these activities are along with medicine that gives an edge and a punch in orthopedics. Any mind development is never wasted. But if you develop only orthopedic practice, fun of orthopedics will be missing. Happier are the people whose hobby is their profession. Again, I will repeat this. Happier are the people whose hobby is their profession. If orthopedic becomes your hobby, then I think you will enjoy it to the nth degree. To me, life is a one-time journey. And life has many facets and we all have tremendous brain power to experience many things. We only use very small part of our brain. Dolakya Tanna already forgotten. Tanna will happen the same way. There is no immortality. At my funeral, if one of you speak very high of me, which you are expected to talk if you attend, हमको क्या फर्क पड़ता? I would have been already waiting for Apsaras in heaven with many of you or in hell with some of you. Once funeral is over and me will be forgotten. Life comes only one. Enjoy.
Great.
This is where I do waste my mornings on weekends. I enjoy. Thanks. I feel we as doctors, majority of us, don't live life fully. And this is what I feel. And that's the reason I've given this talk. There are quite a few things I have spoken about me, but that's not the intention with anything else. I think I very strongly feel one is to really live your life to the fullest. Any questions or any comments? And I refuse to comment on my ways. That is what I am. This is what I say. This is all I will say.
सर आप सामने होते तो तालियां जोर से बजाते हम.
Sorry.
आप अगर
so nice life learning.
आप सामने होते तो जोर जोर से तालियां बजाते. Hands off to you, sir.
बहुत शुक्रिया.
Sir, just
last talk.
Yeah.
बोलो.
जैसे आप करते हैं वैसे हमारे भी लोगों का पैशन है. जैसे I am working in a field. I am very fond of working in a field. I go there. I enjoy the farming and all those things. That is out of my profession. And I have been visiting almost 30 countries till now. And I'm very fond of going for any journey and all that. So as these were inspirations long back from you, so we are doing that. That's all, people, sir. Thank you.
Sir, very honored to see your experiences. Feels live with you, with the tremendous academic knowledge as well as the other things that you have been doing. We try to follow your footsteps everywhere, in every aspect, and would love to be someone like you. Uh, to my smallest experience that I've been practicing and I've been doing my routine work. I am.
Network is bad.
Sir, I am into running since past 10 years. I've been doing 21 kilometers marathon, almost like pre-COVID were five marathons. Five marathons.
Yes.
5 marathons a year. I go cycling either from Mumbai to Lonavala or something like that and back. I am.
Yeah, I think I'm sure many people are doing many things apart from medicine alone.
Yeah. And now my next venture in coming June is a drive from Mumbai to Ladakh and back.
Perfect.
So hopefully I make a good video blog about it and can post it yourself.
Can you see my slide?
Yes, sir.
Huh?
Yes, sir.
Can you see the penguins moving?
Yes, sir.
Okay. So I'll talk about this last talk of our fellowship. All the world travel, wonders of the world. There are 7 wonders of the world. 6 oldies travel the world. Dr. Kulkarni, my wife, Sudhir Babulkar, me, Dr. Mrs. Kulkarni, and Dr. Mrs. Babulkar. 7 wonders of the world: Mexico, Brazil, Italy, Taj Mahal, Great Wall of China, Machu Picchu, and Petra. I am one of those fortunate ones who have done each one of them. I'm going to talk about that and then further up. This is the Italy Colosseum. This was the sporting statement of Italy, Stadium of Italy, which was there. And it is one of those wonderful things which has been still preserved. This was the wonder number 1. This is obviously, you know, this is the Tower of Pisa. And this is the one which is in Venice. You go, and it's a wonderful thing which happens. This is the Great Wall of China. This is where I think I was climbing. I could climb up to here, and then obviously you couldn't go all the way up. This is the Great Wall of China. This is the one which all of us have been together and seen it. And this is the Shanghai. This is one of the most modern cities I have been around. I have been almost all over in the world, but this Shanghai is really the most modern city ever you can think of. This is the Shanghai. This is the terracotta warriors in China. Some crazy emperor made, these are all artificially made of mud. These are all terracotta warriors. There are plenty of them. They are very well known. This is the 3rd wonder of the world. We all know this is Taj Mahal. I'm sure most of us have seen it. But thanks to Dr. Pruthi of Agra, when I went to Agra to give a talk, Dr. Pruthi put me onto this Taj Mahal. I could see like a dignitary. He put on to somebody, and I really had inside things of Taj Mahal, which you could really show it to me. This is the 4th wonder of the world, Mexico, Chichen Itza. This is this thing which you climb up. Fortunately, I had been there when I was young. And higher up, there is almost the whole thing which is there of this big thing. So it's a big one. It is a real wonder of the world. Higher up, you can see all these small things which are there. This is Jordan, Petra. This is also wonder of the world 5. This is the excavation which they have done it. And it's a phenomenal thing. Indiana Jones was filmed here. Large, unique township in stones. You can see this is the one. And these are where all these pictures. It is so popular. These were all the movies which have been filmed in this area. This is a typical picture of that. You can see this. It is really unique to see that. This is me here. Dr. Babulkar is also somewhere around, if at all, I don't know. So this is what you see, Petra. This is the Dead Sea. Anybody knows what is a Dead Sea? Anybody knows what is a Dead Sea?
The salinity of the water is so much you really can't sink in there.
That's right. You cannot sink in. These are all floating people, because you cannot sink in because the saline. And this is the one. At one stage it was ocean, and it got secluded, and it got covered up on all sides, so that it cannot meet the ocean now. The water comes in from small sources, so this water of the ocean gets more and more thickened as the time passes by. And that's the reason it is high salinity, and this is the typical known as the Dead Sea. The Dead Sea isn't actually a sea at all. It's a Dead Sea, it's a saltwater lake. No marine life. Salt content is 33%. You can lay on the surface of the water without even trying to float. The high salt content makes you buoyant. Water flows into the Dead Sea from streams and rivers, but does not flow out. Dead Sea salt is super bitter and not at all like a table salt. I remember when we were swimming in the Dead Sea, I think it is you go it for the heck of it. You cannot remain for a longer time, because I think it is just a fashion which we go there when we go to Jordan, or we go to any of those areas where there is a Dead Sea. In that zone, you go there and you just move around there. This is the sixth wonder of the world, Machu Picchu, that is in Peru. It is built in 15th century and later abandoned and rediscovered in 1911. This is a huge one, Machu Picchu, Peru. Incan citadel set high in the Andes mountain in Peru. And you can see this is the one which is, all these stones have been lying there without any cement or anything. They've been fitted into each other and they remain there stable construct. The 2-hour train trips from Cusco town during the trip after refreshment, same attendants entertain you the time quickly. This is Dr. Babulkar. The same people, they give us the food and the drinks and everything. And once that time is over, there is a journey of about 3.5 to 4 hours or 2 hours journey. So they entertain you and they put you onto that. And this is the journey, a lovely river passing through. We just see that on the way to Machu Picchu. And here is the one, if anybody has seen this picture robot, Aishwarya Rai was dancing over here. This is Machu Picchu, typical Machu Picchu as it is. You can see the whole civilization has now been there, which was excavated, and it is now today the real wonder of the world. Older generation, these are the steps. Older generation people were strong and fit. They could climb all these things. I tried to climb. I could go only up to here, and I was panting around. The steep climb which is there. And now to Galapagos from Peru. This is not a wonder of the world, but this is Galapagos, which is one of those exotic places to travel. So this is Peru, and this is Ecuador. Ecuador is at the zero level, as I mentioned in the earlier picture. It is at the zero equator. This is the zero latitude. Ecuador in middle of the world, calculated with GPS. This is the line. I just explained to you a few things which are wonderful. So all 6 of us are there on the equator there, in the equator there. Now see, this is the one which is the things which are put over here. Something on the south and something on the north.
Namaste.
Now here is this. This is the equator, and here is the water. You can see this. So when you put in the water, you put the leaves will go directly inside. As you can see, they will not swirl around. It is right on the equator. You can see the red line, it is the equator. And he will put the leaves there.
कितना हो गया सर? एटीएम दिखाइए।
So he
प्रेम
sees,
खाला
keep
जो
keeping.
खींच रहा था लौंडा मेरा, हमें लगा गया बोला चट।
See, now he's putting the leaves, taking out the water thing and putting the leaves. Leaves will go directly in that hole.
चलेगा थोड़ा.
Without, they are not swirling around, as you can see. While otherwise it will swirl around, as we know. Now she is going from here. She is going a little distance there onto the south. It is there only in the same terrace. Same terrace she is going. Now the same thing is repeated here.
अब क्या आता है?
सब ठीक है, मेटल में भी अब बड़ा चलने लगा है. Problem ये है.
And see, she will put the leaves now. It will swirl around in a different direction. Now you can see it is swirling around in different direction.
मेटल अब नहीं आ रहा, मतलब हमें क्या लगवाना होगा फिर? हमारे पास क्या ऑप्शन है?
फिर कुछ चीजें अलग-अलग
It is going clockwise. She goes on the other area.
एटीएम आ गया?
Now she will go to the other area.
चलो फिर है
Other side of equator.
क्योंकि फिर वहाँ
She is going. You see a small distance. Other side of equator. And the same experiment is repeated. The petals will swirl around in a different direction. You can see it will swirl around in anti-clockwise, as you can see is happening. Now it is moving in the anti-clockwise. So this is the peculiar phenomena happening on the equator. And there we met this Galapagos. We went to Ecuador and Ecuador to Galapagos. And this Galapagos is the Charles Darwin Research Center. He is the one who first did this Darwin's research. If he did it first here. And all this is the animals which are there around. This is the land iguana. These are in this Galapagos, you see the animals which are not seen anywhere else except Galapagos. This is the land iguana. These are the hawks. This is, I feel, is a walrus, but I'm not sure. All these are the birds which you see. These are totally different. And here it is. This is a national park which is known after Charles Darwin. And here it is Charles Darwin. These are all of us who are here. This is sea iguanas. Again, these are different iguanas. And you can see how small they are. Unique animals in the world, sea iguanas. We requested them to pose for us and they obliged into this line. They all put it into this line. Here it is the sea lion looking after their child. Sorry, this video is not working. This is the sea turtle mating in the sea. We were told it goes on for 3-4 hours. How lucky they are, 4 hours mating. This is a giant tortoise, huge big tortoise there. You can see these are the humans and these are the giant tortoise gently moving around. I think my net is not very good, so they are not moving. These are the videos. Now to Brazil for a wonders of the world. 7, last wonder of the world. This is the Jesus Christ the Redeemer. This is from a distance. And in that Brazil, you can go right up to the base of it. There is an elevator which goes onto this mountain, right all the way there. Huge statue seen from far away, Rio. And you can see this Christ, the Redeemer. This is 7 wonders of the world. Famous Copacabana Beach, Brazil. I was looking for a Bipasa Basu there. This is the parrots, Brazil. No, where you can see this sort of a toucans. You never see this anywhere else. These are typical parrots you see. These are the different parrots again in a different types of things in the Brazil. This is a samba dancer. This is a wonderful dance which we could see.
Sir, your slides
are
wonderful
not Amazon River. You can see the whole Amazon River.
Sir, your slides are not moving with your talk.
Now you are not at the Amazon?
No, we are on at that parrots, multicolored parrots. We were on that.
Oh.
At present, the slide is
Sorry,
of
I think
Ramadan.
there is something wrong with the internet. Okay, I try once. I'll go out and come back. If it works, it works. If it doesn't work, I'm sorry. I'll go out and come back. Can you hear me?
Yes, sir.
Yes, sir.
come in if I can. Can you see my slide now?
Yes, sir. No, sir.
Okay, friends, I think I cannot handle. Anyway, any questions before we wind up? Because I think my net is not working. You hear me at least, you know? Dr. Sangeet, Dr. Asim, do you want to talk anything on orthopedic?
Particular. That is more difficult.
Okay, friends, I think we have enjoyed each other's company. And now we part. Thank you very much. Sangeet, you will say something?
Oh, thank you, sir. Thank you so much.
Thank you very much, sir.
Thank you, sir.
हमको नायर हॉस्पिटल पहुंच गया.
Thank you for sharing your
ऐसा
knowledge.
लगा कि वापस नायर में पहुंच गया.
Okay, bye-bye.
Because nowhere else I could catch you for 3 hours at a stretch. And nobody pressing the buzzer. Time हो गया सब अभी बस stop. We are running behind the schedule.
Thank you very much.
Yes,
Thank you, sir.
Thank you.
Bye-bye.
Thank you,
Thanks.
sir.
Thank you, sir. Thank you.
Thank you. Thank you so much, all the faculty members. Thank you, Tanna sir. Thank you, Sangeet sir, Naseem sir, Gadigone sir. Thank you very much.
Thank you, sir. Everyone, sir. All the faculty members. Thank you so much. Really, it was a wonderful, sir.
So Sangeet sir, thank you very much for
Thank you.
immersing your knowledge.
Yeah. We'll meet again.
Yes, sir. Yes.
Somewhere. Yes.
It was great knowing you and interacting with you.
Sangeet sir, thank you very much.
मीटिंग करना है तो भी होता
Hello. Is the fellowship over?